We're going to be demonstrating a AC joint adjustment. Typically when the AC joint misaligns, the distal end of the clavicle is going to ride superior to the acromion, which is part of the scapula. So it's going to be a superior misalignment of the distal clavicle. And the way we're going to do it, we're going to stand to the affected side. Doctor is going to stand behind the patient. Doctor is going to palpate for the distal end of the clavicle. Doctor is going to use either a meaty piezoform or a thenar contact. Okay? Here we're going to demonstrate the meaty piezoform. So fleshy piezoform is going to be on the distal end of the clavicle, just like that. And the idea is we need to set the clavicle S to I. So we need to bring the shoulder, we need to do shoulder abduction in order to start to approximate the acromion to the clavicle and then set the clavicle to the acromion. So we're going to do passive abduction of the shoulder. As soon as we get to that point and we feel the approximation and point of resistance, it's going to be a straight set S to I, like that. We're going to be going over the adjustment of the AI shoulder with the A major or anterior component is major. Patient is going to be supine on high-low with the middle piece locked. Headpiece can go up slightly. Have the patient slide over towards you where the scapula is on the table, but there's free movement of the glenohumeral joint. Doctor is going to stand inside the affected arm. With the outside hand, doctor is going to grasp or cup the elbow. I'm going to use a meaty piezoform contact on the anterior surface of the head of the humerus. Fingers are going to wrap over the humerus or the head of the humerus. Patient is going to have arm, elbow extended, just like that. Cupping the elbow, meaty piezoform contact on the anterior surface of the head of the humerus, fingers wrap over. Now, the idea is to stabilize the scapula into the table, and it's going to be, the thrust is going to come through the contact hand here. There's no thrusting with the outside hand. This is for stabilization and for guidance. So the more anterior, you're going to bring the elbow up like this. The more inferior, you're going to be down like this. But as we said, if there's a more inferior component, we want to do that seated. If there's an external component of the misalignment, you're going to turn the humerus internally, rotate the humerus. If there's an internal component of the misalignment, you're going to externally rotate the humerus prior to the set. Okay? And it's just going to be a straight set, anterior to posterior, down, like that. Next, we're going to do the SC joint, the sternoclavicular joint. Typically, when the SC joint subluxates, it's going to go superior on the anterior side. It's going to go up like this. So we need to bring it back down and out a little. It subluxates like this. So what we want to do is we want to bring it down. We just want to guide it down this way and in. And it's not really a thrust, it's just a guidance. There can be a little impulse at the end just to help seat it back in place, okay? If there's a lot of tenderness and the patient can't tolerate it, do lots of ice massage. If the patient still can't handle it, then have them come back another time, okay? You want to do this to patient tolerance. You don't want to be adjusting through pain, okay? Now, we're going to go ahead and contact. It's going to be a meaty piezoform contact right on the anterior superior aspect of the proximal clavicle like this. It's a single hand contact and you're just guiding it. And you have the patient take a deep breath in. As they exhale, you're just guiding it down. So it's going superior to inferior and anterior to posterior like that. We're going to be going over the shoulder relocation move. Anytime we're relocating a dislocated joint, we actually need to dislocate it more in order to relocate it. So we're going to be demonstrating the relocation of a dislocated right shoulder. Patient is going to be supine on the high-low or examination table or pelvic bench. Doctor is going to extend the patient's elbow, bring the arm between the doctor's thighs, grab right underneath on the thumbs are on the head of the humerus and the fingers are right behind. So it's anterior, it's already dislocated. We've got to dislocate it more, bringing the head of the humerus more anterior. Now, so we've cleared the internal structures, maintain S to I traction down. With traction, abduct the shoulder out 30 to 45 degrees. At that point, now we want to bring the humerus back towards the body. We're going to do that with internal rotation, which is going to create a stretch reflex and suck the shoulder right back in, just like that. Okay? One important thing we want to go over that's not part of an articulation, but it's very important in the stability of the shoulder complex, and that's the biceps tendon. That's right here. In the head of the humerus, we have what's called the bicipital groove, and the biceps tendon sits in that groove, and there's a transverse ligament that goes above it to keep it in place. When we have a severe trauma misalignment of that shoulder of the humerus, especially when it externally rotates, or even if it internally rotates hard, it can cause the biceps tendon to go out lateral, and it doesn't sit in the groove, and so we get a popping, a clicking of that, and a limitation of motion. If it's a severe enough trauma, we have damage to the transverse ligament. If the ligament is damaged there, the tendon stays out there, we lose the proper function of that shoulder complex. So this is one move that not a lot of people do. There are very few doctors and therapists out there that actually know about this. So we want to demonstrate this and show how simple this move is and how effective this move can be for the overall functioning of the shoulder. We're going to go over the biceps tendon lateral reduction move. Patient is supine on the high-low pelvic bench or portable table. Doctor is standing on the affected side. Doctor is going to place the patient's arm between doctor's thighs. Now, for this particular one, we're going to be proximal to the elbow. Okay? Doctor's inside hand, thumb, is going to contact the lateral aspect of the biceps tendon. Okay? So what we're going to do here is we're going to contact the lateral aspect of the biceps tendon. We're going to roll it back into the groove. We're going to superimpose the outside thumb, and we're going to bring it right back in, and then we're going to set the shoulder A to P like that. Now, it's not obviously a true joint. Are you going to get cavitation audible? Once in a while, you may get an audible as the swelling is being cleared. The idea is we have to get that back into the groove, number one. Number two, we'll do taping, rehabilitation, and some nutritional support to help speed up that process. We're going to be going over the adjustment of a posterior misaligned shoulder, and we're going to demonstrate it on a high-low bench. You can do this on an examination table. You can do this on a pelvic bench as well. Patient is going to be prone on the high-low. Middle piece is going to be locked. Head piece is going to be level. Doctor is going to stand inside the affected arm, affected shoulder. Doctor's stabilization hand is the outside hand, is going to be cupping and holding the elbow like this. Okay, so the shoulder has gone posterior. Now, let's bring the hand here. Want to set the glenohumeral joint posterior to anterior. We're going to start by standing on the inside of the patient's arm. We're going to use our stabilization hand, the outside arm, to grasp or cup the patient's elbow. We're going to abduct the shoulder 40 to 75 degrees. With the inside hand, we're going to cup the back of the head of the humerus like this. For a straight posterior shoulder, the elbow is going to be parallel to the floor, as we can see here, and the thrust is going to be straight P to A like that. Okay? If it's a posterior superior shoulder, then we're going to bring the elbow up. It's going to be higher than parallel. It's going to be superior to parallel of the floor. The thrust is then going to be P to A, S to I, this way. If it's a posterior inferior misaligned shoulder, glenohumeral joint, we're going to bring the elbow below parallel. The thrust, we're still using the web contact. The thrust is going to be P to A, I to S, like that.